Hi, I'm Rushi. I'm one of the orthopedic registrars currently working at Starship. This study hopefully will shed a light on a couple of things for the rest of you guys, but for Dr. Matt says it might be old news. So this was done when I was here as a house officer and registrar last year. So why do we have to worry about septic arthritis? Well, it's a condition that causes a lot of pain, impairs ambulation, and if not treated, can be a focus for sepsis in most people. And in the very young, it can destroy cartilage and leave them with quite bad issues in the future. The premise for this study is based on another published by Miriam van der Boom and Mr. Crawford from Starship Hospital in 2016, where over a course of 10 years from 2004 to 2015, they looked at about 68 children under the age of 5 who were treated with who were diagnosed with septic arthritis, and found 12 cases of Kingella kingi, and all of them in kids under the age of 2. Essentially a niche that used to be occupied by Haemophilus influenza B before the introduction of the vaccine. And another reason for the study is to actually figure out what is going on within South Auckland. Who's affected, what our common pathogens are, what our investigations are showing, and how we're actually treating them. So it was a retrospective look at our data and all children treated under the age of 15 at Kids First between 2006 and 16 with those discharge ICD-10 codes. So we defined septic arthritis in our study using those 4 criteria. So A and B is culture positive. So A for an aspirate, culture positive. B for a blood culture positive, given the right clinical context. C for a cell count of greater than 50,000 from the joint aspirate. And D for surgical findings that are consistent with septic arthritis, synovitis, and frank pus out of that joint. All of this is obviously in a child who presents with an acutely painful single swollen joint. So 122 patients matched our criteria. 82 were boys and 40 girls. There's a clear gender discrepancy, and looking towards the literature, the most that I could find was a study published by Wang who shown 60% males. And the previous study that I was alluding to by Miriam has got 59% boys. So this is kind of on the top end of the spectrum at 66% being boys, and an average age of 5.77 years. And once again, looking at that specific subset of population, those kids under the age of 2 that Miriam's study has found to be most commonly affected with Kingella, we had 43 children under the age of 2. 31 matched our criteria A and B, in other words, culture positive, and another 12 matched the criteria either C or D. So when we're looking at our ethnic distribution, the blue bars on the left are our general population distribution. So we've got about 20% Maori, and I think this was alluded to before as well by Nathan, our general population distribution. And the red bars are the patients that we deal with or we treat. As you can see, there's a clear sort of overrepresentation actually across that. The red bars are the normal population, and the blue bars are the patients that we treat. So overrepresentation of the Pacific people and Maori, and underrepresentation of European, and gross underrepresentation of the Asian in a good way. And when we look at our socioeconomic deprivation in children, 9 and 10, or that end of the scale being bad or more deprived, and this end being, well, more well off, you can see that there's a gross overrepresentation of those in the most socioeconomically deprived. So that's deciles 9 and 10. And numbers-wise, 36% of our population live in deciles 9 or 10, whereas 80% of our patients come from these deciles. And coming back to our septic arthritis, or the joints that are most commonly affected, and this is once again consistent with the literature out there, joints that are weight-bearing, hips, knees, ankles, are the most commonly affected. And the thing to note is 117 out of our 122 patients had a single joint involvement, whereas 5 cases of multiple joints being involved, and often they're in the foot or in the hand, and they're generally adjacent joints. So the old age adage that if you've got a single hot, painful, swollen joint, septic arthritis until proven otherwise seems to hold up. And vice versa, if you have multiple joints that are involved, it's probably unlikely to be septic arthritis, but never say never. Basic investigations wise, an average admission white cell count was 82. CRP was 82, and white cell count was 13. A thing to note is another study published by Raki Mistry from Starship Hospital, where they looked at rheumatic fever, and in those kids, they found an average admission CRP of 94 and a white cell count of 14.5. So just biochemically speaking, these two tests are not enough to differentiate a septic arthritis from a rheumatic fever. Well, when we look at aspirates, 99 out of the 122 children had an aspirate performed. 70 had cell counts that were available, and 46 cases had cell counts greater than 50,000. In terms of gram stain, 95 patients had gram stains that were available, and out of that, 28 were positive gram stains. And interestingly, all of them went on to culture a gram-positive pathogen. In those 67 that didn't have a positive gram stain, 22 went on to culture a gram-positive pathogen, and 7 another gram-negative pathogen. Blood cultures, 103 patients had blood cultures on arrival, and 33 were positive. And in 16 cases, the diagnosis of septic arthritis was made exclusively based on a positive blood culture, given the right clinical context of an acutely painful swollen joint. So the overall microbiology of our patients, out of the 122, we were able to culture a pathogen for 88 of them. And as you can see, MSSA, or methicillin-sensitive Staph aureus, still accounts for 50% of the pathology, and MRSA is seen in about 3%. And Kingella, which is what I was alluding to earlier with Miriam's study, accounted for about 6%. And speaking of Kingella, it's our little subset of population. So out of the 43 children under the age of 2, 31 had positive cultures. And out of them, all 5 Kingella were seen within this under 2-year-old subgroup. MSSA was still the most common. Now, quick word about Kingella. It's a gram-negative pathogen, a Coccobacilli. It's quite sensitive to amoxicillin and therefore augmentin. And it's very sensitive, so even giving antibiotics in the community can alter your pickup rate. But it's also quite difficult to grow in the lab. Like Starship, we do enrichment cultures in all our samples here at Middlemore Hospital. And of note is another study by Lowdy from Christchurch, where she's shown that a PCR is a gold standard, and culture or enrichment cultures are pretty poor, and so poor that it's only about 20% of a PCR. So for us to do a PCR, we have to get microbiology approval and send it off to Lab Plus. It costs about $150 to $200. So if you're still suspicious that a kid might have a Kingella as a cause, then you can send it off to the lab after some approval from microbiologists. A quick side note, or an interesting point: do antibiotics obscure findings? Well, 36 patients were on antibiotics either given by the GP in the community or were started for some other reason at the time of the aspirate. 64% of them ended up culturing a pathogen, compared to 59% in antibiotic naive. It's quite interesting because this just reassures us that whatever practice that we're doing at the moment is acceptable. And as for the guidelines on the website itself, if you have a sick child and you're worried about a septic arthritis, give antibiotics, don't wait for the aspirate. So far this shows that we haven't burnt any bridges, but it doesn't go ahead and say, oh, you should be giving antibiotics to everyone before aspirate. Management was flucloxacillin empirically for 91 patients. And those kids under the age of 2, antibiotics with flucloxacillin was done about 75% of the time. And about 11 of them, or the other 25%, needed change of antibiotics once the cultures had grown or come back. So in summary, Maori and Pacific children, and those are the lowest deciles, are the most commonly affected. And lower limbs are most commonly seen. MSSA is still the most common pathogen. But coming to Kingella, I think it's quite important for us to realize that now with the introduction of the Haemophilus influenza B vaccine and oropharyngeal carriage rates within New Zealand, that if you get a child under the age of 3, then cover for Kingella instead of not covering for it. And the practice has changed, and I've just got a picture. I just cheekily took a photo. This is Auckland Starship Hospital. They've got this print out within the ED and also on the ward. It's just been done in 2018, and the guidelines have been updated as well. So any child under the age of 3, you do Kefsol and Augmentin as an empiric treatment. It's just another study. Questions?